Hi, everybody. Hope everybody can hear me okay. We'll just give it another 30 seconds or so to start. We are recording from this point, just so that you're aware. Laura, is everything okay at your side?
Yeah, all good.
Okay, good. Thank you. So I'm just going to give it another minute and then we'll make a start. If anybody has any difficulties in seeing anything, and just let us know in the chat. Lara's there in the background for any technical things. But hopefully it'll all go smoothly. Okay, so we're just going to make it, we'll make a start. So welcome those that have been able to join us. We've actually had an awful lot of people subscribe for this. And most people seem nowadays to watch these on recording. So if you're watching on recordings or on a recording, you're very welcome. My name is James Hamill. I'm CEO and Clinical Director of Course 3D, a digital dental laboratory based here in Northern Ireland that specialises in full arch guided surgery as well as full arch restorations. And this evening we're going to talk about what you can see on the heading, which is full arch restoration in just 2 appointments, and how we can guarantee you passivity. So that was a good start. Let me see. So we have aims and objectives, obviously, for your CPD at the end. There will be a barcode that pops up. Please feel free and be ready when we come to the end to scan that, and you will have your feedback form, and you will be able to request your CPD, which obviously you will want, which will be 1 hour for this evening's webinar. So what we're going to cover is we're going to look at a few things. The first point is we're going to have a little look at traditional full arch restoration. So what's the sort of normal analog based type workflow? And if you've been doing dentistry for as long as I have, a lot of it will be familiar to you. If you're newer to full arch dentistry, then maybe you'll be wondering what some of it is maybe, but it's worthwhile us just running over that, because it gives us our basis as to where digital technology can improve those situations. We're going to look at the overall digitization of restorative full arch workflows, the growing demand for that, because the demand is getting more and more. The barriers, because there are some practical as well as perhaps psychological barriers to getting involved, as well as the rewards for not only you, your patients, but also your practice of getting involved. This will really fall under the platform of what we call DigiBridge. DigiBridge is a new and exclusive digital full arch restorative solution based here at Course 3D that we have developed and created really over the last 18 months, largely based on listening to our customers and to what is happening in the market. We're going to shine a spotlight on the topic of passivity. It's a very popular topic at the minute, and one that isn't overly clear, but we'll certainly have a little look at it on how we can help you achieve passivity on your cases, no matter your starting point, with what is called passivity plus technology, which has been created by our partners Rowe Dental Laboratory in the USA. So DigiBridge has 4 main restorative pathways. It is photogrammetry, grammetry arch bridge, grammetry OptiSplint, and iJig, and we will look at each of these. And we're also going to talk a little bit about how you can choose the right DigiBridge pathway for you, for the cases that you are seeing, but also your practice. And we'll look briefly at the end at how things are priced and packaged and how you submit cases. Hopefully at the end we'll have time for Q&A, and if you have any questions, please feel free to pop them into the chat, and I'll do my best to answer them at the end. So if we were doing things traditionally, and certainly this is how I used to do it, we would start life off with a stock tray and a little bit of alginate. And really what we were looking to do was give the laboratory, I suppose, a baseline index of where the implants in the mouth were. And from that point, the laboratory would have a few options, but probably the most common would be to create a special tray, which would be what's known as an open special tray, where it was sent back. And the idea of this was to be able to pick up the implant position using those fiddly old impression copings, which could be splinted at the time or often not. And that would allow you to really provide the lab with two specific bits of information: implant position and soft tissue. Nowadays, obviously, if people want to do that, we can create those special trays via digital methods and print them. But essentially, the information gathering of this is exactly the same. And often on this, which would be your appointment 2, so you'd do your impression, you would also have something like some form of wax room. And ultimately, what the information that this was providing to the lab was the vertical position, the bite, center line, transition line, smile line, that type of information. And this was all shipped back to the lab. And really, to be quite honest, an awful lot of dentists still work like this, and a lot of labs still work like this, sometimes in a little bit of combination with digital. Funny, I ran a course last week, and out of the 14 dentists there, only 2 were using digital workflows for their full arch restorations. So it's still, the stuff I'm showing is still very popular. So the lab would cast up what would have been called, I suppose, some form of plaster or stone model that then needed to be verified. Now, sometimes this stage would be skipped, this verification stage would be skipped, which can potentially lead to problems further down the line. But really what should happen would be some form of verification jig that would be made on that initial model. So this would be an unverified model that now needs to be verified through a verification jig. And there are lots of different ways of making that. We don't have to go into all the different methods, but ultimately this can be sent to you divided up, or it can be divided or set in one piece, which you then may need to section and readjust and relute inside the mouth. So that would lead to appointment 3, which would be the verification. And ultimately what we're trying to do there is ensure that what is being seen in the mouth in regards to implant position is being transferred to the laboratory. That's the only reason that that exists, to make sure that both of those situations are the same. But based on the wax block or the wax setup, a wax trine could be created, which would now start to give the patient and yourself an idea of where things were going to go in terms of vertical bite and tooth position. Also an aesthetic check, a shade check could be done at this point. But we still had to have this appointment as appointment 3. From there, the lab would then take the verification jig back, check it on the original model, and if they had to adjust that model, change an analog, etc., then ultimately they would do so to create, I suppose, what we would call a verified stone model. This would be then the final positions of the implants, which then would be used for the restorative process. And that model could be then scanned. It could be used to form a wax trine of a bar, or a wax frame for a bar, which would be cast. Or in some labs, it would have been slightly more digital at the point. They would then maybe employ an outside milling center to then create some form of digitally milled framework, but ultimately they were producing a framework. And as you can see in this picture, this framework is attached direct to fixture, which would have been the traditional way of restoring full arch cases. However, as we know now, it's much more popular to go from MUA or multi-unit abutment level, so abutment level rather than fixture level. And this certainly has made things easier for full arch restoration, but I'm still surprised that certainly in our lab how many cases we still get in where the dentist is looking to go from fixture level rather than MUA level. But ultimately there's going to be some creation of some metal substructure. And at this point, depending on how you work, that substructure can be sent directly back for verification or fit in the mouth. Now, this could be coupled with trying of teeth over the top, but quite often this was done as two separate appointments so that you really could assess in the mouth as to whether this metal substructure actually fitted or not. And these come in all shapes and sizes, depending on what type of restoration you're looking to achieve. But ultimately, there had to be some form of approval of that fit of that metal substructure. And this often led to another appointment, or appointment 5, which was where once the metal was confirmed to fit, the lab would go ahead and start to take the wax up from the original try-in and convert that across so that you were now having something that you could screw down inside the patient's mouth to be able to give them a better sense of what the final restoration would be like. And ultimately, at that point, if everything was going well, you would get towards your final fit, be that in bonded ceramic, be that in acrylic, be that in composite, but generally it was a metal base, usually direct to fixture, with some form of wraparound material, which then would have been fitted as the final restoration. Now, quite often you could maybe squeeze that to 5 appointments, but certainly in my hands, many times that ended up being 7, 8 appointments because there were certain things that needed to be done. Maybe there was a communication issue with the lab, maybe there was an impression issue, the metal didn't fit, the bite wasn't right, adjustments, and all of this took quite a bit of lab time. So ultimately we were looking at all of these various stages. The more stages we have involved, the more possibility we have for errors along the way. And ultimately that created a reasonably time-pressured and long-winded way of restoring these cases, often taken anything between 3 and 5 hours just to restore a single arch, because most of these appointments are going to be between 40 and 60 minutes long. Okay, so that was typically how things were done. And as I've said, I've been amazed at the courses that we have run in our premises here, just how many people are still actually working in this way. But we know the demand for digital workflow is growing across all aspects of dentistry, and full arch is not excused from that. Certainly in implant world, I would say that the singles and the small bridges have been largely digitized by now. However, I was speaking to a dentist at the weekend who still is doing conventional impressions for all of their implant work. And certainly I don't think that they're alone. But we know that the demand is there. Why is the demand there for these types of workflows? Well, I think there's a certain amount of FOMO out there, and there's a fear of missing out, and an awful lot of dentists are looking at this. And there's no doubt that the trend for digital dentistry is strongly going through the profession. I suppose the last few things to be digitized, such as dentures and these types of workflows, still have yet to be really embedded. However, the trend is definitely there. And really we can see two main drivers from a clinical perspective, but also from a commercial perspective. Certainly within the clinic, the less appointments we can handle these cases in, the better. Okay, it frees up time, it makes us more efficient, it allows us more time to do some other work, and it takes a little bit of pressure off the diary. Because if you're doing a lot of this type of work, it can really start to build up within the diary if you're doing 5, 6, 7 appointments per case. There's no doubt about it that digital technology allows us to be potentially more accurate, I think I have to say that that also depends, just like analog workflows, on the quality of the record, which is absolutely critical. And just because the record is managed in a digital format, it doesn't mean that we in the lab can make a poor digital record a good digital record. It's either a good record or it's not. And in fact, digital has probably exposed some of the little things that we maybe could get away with an analog approach. So accuracy is definitely available to us, but the quality of the records cannot be overlooked. It does provide a smoother clinical process if we can reduce the number of appointments and create a very systemized process. Then that allows for smoother clinical appointments. And that's certainly the experience of many people who have moved over to these types of workflows. Definitely, we can eliminate the verification steps. And what I will show you in DigiBridge, 3 out of the 4 pathways do not have a verification step required now, simply because of the types of records and the way that they're taken. Certainly as well, we've got improved communication. Digital workflows allow labs and dentists to communicate better. There's less scribbled notes on soggy wet bits of paper that come in with impressions. And via email and screen sharing, etc., things can be much more easily communicated. So this is very, very important, and it's a big advantage of digital workflows. At the end of all of this, in terms of how good are the labs at producing things, the digital aspect has certainly improved the manufacturing precision. Very accurate milling machines, very accurate CAM technology allows for an accurate result. And so that is overall creating this environment where better results are possible in faster times with reduced appointments. And the commercial drivers are certainly important. Most of us are running a business, so by reducing chair time, which is one of the most expensive parts of running your business, this allows you to do either more work, employ more people, etc. So that's a really important aspect of it. Full arch dentistry can be expensive, especially when it's unpredictable, especially when you're not too sure just what you're going to get at the end. And so digital workflows are allowed by increasing the predictability. It's also increased the predictability of the cost base for doing these types of arches. And that has allowed us to improve the profitability per case. What is also interesting and is being looked at, certainly by lots of the larger group practices, is how scalable these processes are. Digitizing full arch workflows is incredibly scalable and doesn't have to cost an awful lot of money. So if you're working between different practices, if you're working in a big practice that's got lots of surgeries, these types of workflows can be incredibly productive. And you can really start to see a return on investment on the equipment such as iOS, photogrammetry that potentially has already been purchased. But one thing that's really important to think about on top of all of this is now the demand for passive predictable fits. Everybody has gone passivity mad as well as digital mad. And we do need to look at that and understand why it's important. Because for many years, and certainly passivity has really only come into the equation over the last 4 or 5 years in these types of workflows in a big way, because it was often assumed, it was often sorted out by the laboratory through maybe some trickery to make sure that things fitted. But it's now almost a non-negotiable in doing this type of work, especially if you're doing it at volume. You do not want to have passivity problems because you will have issues further down the line. We will talk about that in a few minutes. But getting involved in digital workflows, there are certain hesitations that creep in. And one of the things that we spend a lot of time in our lab doing is talking to dentists about trying to answer this question, which is, where do I start? And these can be experienced dentists, experienced implant dentists, but just being able to work through some of these more complex cases can raise a lot of questions, and there can be a lot of clinical uncertainty. One of those is simply the terminology that's used, the language that's used around these types of processes can be quite confusing. Photogrammetry, grammetry, passivity, microns, how important is the micron fit? All of those things start to raise some questions. Also the data. So what data is required from you, the dentist, to be able to send it in to us in the lab to allow us to be able to take these cases forward. Data is a huge problem, and missing data is even a bigger problem. So what do you need to be able to provide? It's an important question to answer. There's also a lot of promises being made, and there's a complete obsession with the micron accuracy of everything, as if that's just the be all and end all. It's an important part of many links in the chain. Okay, you can have brilliant micron accuracy at the start of the data process, but if it's poorly controlled going through the softwares and into manufacturing, you lose all of that advantage. So we have to be a little bit selective and careful about how we're using microns to defend some aspects of these workflows. It's just part of the process. There is sometimes a mistrust we have found for dentists restoring on MUAs, because traditionally it has been all direct to fixture. MUAs are an amazing addition for full arch. They make life so much easier. Some people have had bad experiences, such as screw loosening and screw breakage, but that's nearly always down to problems with records, inaccuracies, and poor passivity. But if implants are in the right place, you can restore very, very straightforwardly in MUAs, and they make life so much better, a much more predictable restoration. So there can be trust issues around the types of components that are used. And interestingly, skill is a big one. I had a conversation with the clinical director of a large corporate DSO, and one of the biggest barriers to using digital workflows was embarrassment or fear from the dentist, looking silly in front of nurses and looking silly in front of patients, simply because they're not too sure or they haven't learned the skills yet of using iOS scanners. And this is something that hopefully we will be able to address as the profession moves on. But it certainly is something that needs to be thought about. And then there are some confusions over the materials used. So am I okay to use monolithic zirconia? Do I need to put a metal bar in it? Do I not need to put a metal bar in it? When do I use certain types of materials? And there are some concerns regarding that. So there's actually a lot of questions that arise from a clinical perspective. There's also questions that arise from the commercial perspective. One that I call the digital cycle seems to concern a lot of people, which is, if I go down this line, what are my ongoing costs going to be? Updating software, updating equipment, and does this really stack up for me in regards to the amount of work that I do? So that's something that is there and something that people are worried about. They're also worried about, what's the cost of this case? How much is this going to cost me, and how much do I have to quote my patient? Do I have to give myself a buffer for things going wrong, etc.? So there's a certain anxiety around restoring some of these cases, especially if it's restoring an older case. And overall, that leads to questions in regards to the investment that's required to get involved. Is there any investment? Is there not? And that can be thought about in terms of, what are the volumes? Do I do one of these arches every 4 months? Do I do 10 a month? And what's my best option if those are the types of numbers I'm doing? And then the third aspect of that is, who do you partner with? Not all labs are able to handle these workflows, and not all labs have the internal skill sets to be able to do it. As we know, dental technicians are becoming rare and harder to find, and certainly having dental technicians with the experience of these types of workflows are not easily found. So there has to be a very smooth process within the lab to be able to handle it. The CAD ability, so have the lab got access to CAD designers who understand these things, because not all the CAD designers do. how accurate and what is their attention to detail and handling the records will have a direct outcome on how predictable the results are, the types of designs that they create. So there's certainly some things to think about there. And then finally, and not to be overlooked, is the actual accuracy of manufacture. So how good is the lab at producing the final work? So do they have the access to the correct machinery? Is the machinery perfectly calibrated? Is it well monitored and looked after, etc., etc.? So all of these things all go into the mixing pot for people who are thinking about these types of workflows. And some, to be quite honest, they're not really fully aware of. And this, I suppose, ultimately means moving out of the comfort zone for many dentists, and they feel a little bit exposed doing it without training, support, or even just the clarity. And that is ultimately why we created DigiBridge. So as I said at the start, this has really been due to us listening to our customers, talking to people at shows, talking to people all the time about how digital should integrate into their practice. We have a great advantage in that we see a lot of dentists through our courses who are all dealing in some way or another with full arch cases. So again, we've taken a lot of that information, and also from the work that our partners Rowe have done in the USA. And we have really created this process. And essentially what DigiBridge is a range of streamlined pathways. There are 4, and these cover all the main ways of completing a final bridge using digital methods. So no matter the situation that you're in clinically, there will be a pathway that you will be able to choose. It's brilliant in that it meets you where you are in terms of your technology. All you need is access to an iOS, and you can use these pathways. And also it is related to your case volumes. You don't need to go out and invest in any expensive equipment. You pretty much will have what you need already in your practice. And what we've done is we've tried to take that information and put it into well-organized steps. So each of these pathways, of which there are 4, have 2 defined workflows, which allow, and I'll show you these, which will bring you through each of the clinical steps that are required. So everything is well directed. And finally, we've put it into online ordering, which I'll explain why at the end. And very importantly, we've given you fixed and transparent costs. There's no guesswork, and there's nothing hidden that's going to come up and bite you. That will be of surprise. So that's essentially what DigiBridge is and why we've created it. Okay. So these are the 4 pathways. And as I've said, no matter what your starting point is, you're going to get the same predictable outcome. On the left-hand side, we have photogrammetry. Photogrammetry is probably thought of in many circles as the gold standard in how we record implant position. Now, please remember that that's all it does. It just records implant position. You still have to have an iOS or an intraoral scanner alongside it. Okay. It's typically used in high volume clinics because it is expensive to get invested into, but please remember that it's not without its problems. Okay, it's as good as the operator and it's as good as the lab that's handling the data sets. So if you've splashed out on a photogrammetry kit, then there's no question that DigiBridge will work for you. It's certainly one of the workflows. But photogrammetry isn't accessible to the vast majority of dental practices. And this has led to the creation of grammetry by our colleagues Rowe in the USA. And within grammetry, we've got 2 distinct pathways. We've got ArchBridge, which is their designed horizontal scan body that is unique in the UK and in Europe to Chorus 3D. And this is designed for a fully digital model-free workflow with the added benefit of the passivity plus tie-base, which I will come to. This will guarantee you passivity with these cases, and this is ideal for clinics who are doing a few bridges, maybe 4 or 5 over a course of a couple of months, because it's a reusable system. Okay. We've then got grammetry optisplint, which is a very useful tool to have in your practice. And this is almost ideal for people who are just doing the odd case, so low volumes. But it's also important because it has a few distinct advantages, where you can create a model where it can be lab scanned. It also acts as a verification jig. So you get a little bit of an analog physical model to work with, which some people prefer. And this works extremely well. So grammetry optisprint we will also cover. And then lastly, we have iJig, which is actually a very popular product in the laboratory. And this is another workflow that creates a sectioned jig, which acts as your temporary bridge. And this can be used in direct to fixture as well as ANUA. Now, direct to fixture is always going to be more challenging. We have to remember that. But this does give us a little bit more flexibility, and a few more options for some of those more maybe challenging cases or cases that are just that don't fit into the first three. So iJig is a very useful tool to know that it is at your disposal. So how do we guarantee passivity? So what is it? Essentially, passivity is where a restoration seats fully down, either inside the implants, which is difficult, or onto the top of multi-unit abutments with no flex whatsoever. There shouldn't be any strain or distortion within the prosthesis, so it shouldn't have to be forced into place. If you have to force a prosthesis into place in a full arch situation, you do not have passivity. So it ideally sits across all the implants simultaneously, seats down perfectly with no strain on the implant itself. Strain on the implant itself will cause you problems, which we will cover. And you ideally don't want to feel any tension in the screws. One way to see or to check if passivity is there is there tension in the screw as you're screwing the bridge into place or the framework into place. So you shouldn't really find that there's any hidden stress in there. It really needs to be verified clinically and not assumed that it is just going to happen. And ideally we want to confirm tension-free fit. That's what we're ideally looking for, but it's not easy to achieve, okay? And really achieving 100% passive true fit is pretty much almost impossible. If we think of all the various stages that take place from impression or IOS capture all the way through to the final manufacturing, little small discrepancies will happen, whether we like it or not, at every single step. And although the prosthesis that you get at the end may look perfect and feel reasonably well when it's seated, there can be an internal stress or pressure that you won't be able to detect. And this really has led to the production of what's called the passivity plus tie base. Now, when a prosthesis isn't truly passive, the stress has to go somewhere. It just doesn't disappear just once you screw it down. It transfers itself somewhere, and you're going to have three main signs that your prosthesis isn't passive. Number one is screw loosening, and often people will just blame the implant system or blame the screw or say the screw's too small or you don't torque it down a lot enough. But often it's actually due to the fact that there's stress, constant micro stress on that screw. And this creates loosening, the bridge is becoming loose and the patient having to come back to get them tightened. And this creates frustration and the patient questioning their investment. If you've done enough of this work or enough implant dentistry, screw loosening can be a problem. We can also end up with prosthesis fracture, and that's really where the stress doesn't disappear, it transfers through the prosthetic. Just putting a metal bar in will not get rid of this. The bar won't break, but the stress will be transferred somewhere else, and that's usually to the sleeve of zirconia that goes over the top. So this can lead to catastrophic failures and very expensive remakes for the patient and yourself. And this is not something you want in your business, especially if you're looking to do more and more of this type of full arch work. And thirdly, which is probably the most insidious consequence, is really bone loss around the implant. So stress onto the implant caused by an ill-fitting prosthesis will accelerate peri-implant bone resorption, and this can obviously threaten the entire survival of the restoration. So these are situations that we don't want to find ourselves in. And testing for passivity is really difficult. People will talk about the Sheffield test or the one screw test. I don't know about many of you, but doing that in the mouth is not very easy. It's very difficult to see. And really that's a bench test. It's not really a test that's suitable for the mouth. You can have visual and radiographic confirmations, and ideally, you want, can you see a misfit? Is it big enough? If it's big enough to see, you've got a serious problem. But there are different ways that people will try to ensure that their bridges are passive, and you've got to have some sort of clinical process, be that x-rays, be if you believe in the Sheffield test and you want to do it and you feel that it's accurate enough for you. Sometimes it's visual, sometimes it's that tactile feel on the screw whenever you place the bridge. But we need to have some way to assess it. But it really is very difficult, no matter what anybody tells you. So this is where Passivity Plus comes in. Which really is designed to relieve that stress of really understanding and trying to figure out, is this bridge passive or not? It's a very clever little device, and it's ultimately a tie base which goes into the base of the bridge, and it can be added to any of the 4 workflows within DigiBridge. But the Passive Plus is a self-adjusting base. It's made up of 4 main areas or 4 main parts that essentially, as it is screwed down, it tightens within itself and creates a cold weld, which allows the 2 parts of the tie base to be firmly locked together. Okay, and it looks a little bit like this. Okay, so we've got the outside part, which is like a normal, I suppose, like a normal tie base that's then cemented inside the prosthesis, be that metal or be that zirconia. There's a screw which is tightened to 25 Newton centimeters down through the middle, which then locks the 2 bits together. This bit at the base that you can see is called the bell, and the bell takes up any slight micro movement and discrepancy as the bridge is being screwed down. And these 2 parts, okay, of the outer wall and the inner wall, whenever the screw is tightened, then cold weld together, and that gives you the mechanical stability. And there's a little patented washer in the top around the screw head, which essentially stops the screw from centering, which allows it to take up the slightly different position as the discrepancy is taken out of the bridge. So it's a pretty cool little device. And this is a short video just to explain it. So here we have a situation of MUAs. So these are the MUAs and these are the scan bodies. And this is probably the most inaccurate way to scan for a full arch bridge, which is using what are called vertical scan bodies with an IOS. No wonder you're going to have problems, and I can guarantee that they won't fit particularly well unless you use Passive Plus tie bases. So here we have the situation that often occurs, and you can see that there's a very slight misfit of the tie base to the MUA, and this causes stress and strain within not only the implant but also within the prosthesis itself, and this can lead to tie base debonding. This can lead to fracture of the prosthetic, screw loosening, all of the things that we've talked about. And even putting a metal bar within that isn't going to overcome all of these problems. So this is a little animation of the way that the tie base works. You can see the bell moving at the base, and this helps eliminate any gaps and misfits. And this is the little screw and how it moves. It's the little washer around it. And here we have the same bridge, only this time it's made again onto MUAs, but it's made with the Passive Plus tie base. And you can see as it's gently screwed down, the bell at the base moves to take up any of the discrepancy. Obviously this is enlarged. And once it's then tightened down, you form the cold weld and everything is held firmly in place. So when you seat something with these passivity tie bases in place, there is a certain sequence, and it's all about allowing the pivotable caps, those little bells, to compensate for any misfit in terms of positioning. Okay, so you screw it down just 2 to 3 turns to get it engaged. And then once you've done that across the arch, then you're going to do some cross arch tightening of all the screws until you finally torque them down to 25 Newton centimeters and engage the cold weld. Okay, so that's how it works. And this is what it looks like. This is a zirconia bridge with passive tie bases cemented inside it. And this is the little bit that I showed you. This is the little bell that is the movable component. Okay. And here's a case. This is one of my own cases where we did it within a metal bar for a pterygoid case. Notoriously difficult to get passivity on these long span bridges away to the back of the mouth. And this worked beautifully. This is a titanium milled bar that we milled in the lab. We added in the passivity plus tie bases and then a zirconia sleeve. So it's a pretty nice tool to have at your disposal. So let's look at the various workflows that exist. So remember, there's 4 pathways, okay, and 2 workflows. And in each of the pathways, we've got the main, which is probably the most common, which is moving from a temporary bridge to a final bridge. And then the second workflow is moving from a temporary denture to a final bridge. So I'm just going to take you through that. A lot of the information is the same. Now, we have tried to keep it that way on purpose to try to keep things as straightforward as we can. The first thing is to capture 6 photographs. We're going to ask you for a total of 12 records, 6 photographs and 6 iOS scans. Okay, so 6 and 6. 6, not 5, 6. Okay, so we're going to ask for those photographs that you can see. So a full face, full smile, an exaggerated smile, and a full face profile. It is really important you provide us with photographs if we're going to design, especially in 2 appointments, a full arch restoration. We cannot do it without photographs. And just having a close-up photograph is not enough. We must see the full face. This is a skill that we've taken through from guided smile and using an analog process called the rapid appliance transfer. And we've become very, very good at doing that in 2 appointments. And this has allowed us to carry this skill across into DigiBridge, which is still allowing us to do it largely within 2 appointments for the vast majority of cases. But we have to have really good records. So we're then going to do retracted photographs of the bite from the front and from each side. So that's your 6 photographs. We're then going to ask you, remember, we're working from a temporary bridge here, to take your first 3 iOS scans. So you're going to do an opposing, in this case it's the upper, with the temporary bridge in situ, in this case it's the lower, so an upper and lower scan, and a digital bite. Okay, so those are the first 3 scans, just like you would do for any other implant work. Okay, so pretty straightforward so far. We've got our 6 photographs and 3 of our 6 scans. The next thing you're going to do is now remove your temporary bridge. And we'll ask you to do a 360 scan of the bridge in your hand. Importantly, we want you to attach analog scan bodies to the base of the bridge. Now, if you use arch bridge, they come in your kit. If you use arch or an OptiSplint, they also come in your kit. And it really allows a much more accurate stacking. Remember earlier on we talked about the skill of the lab in taking all of this information and putting it together. By adding these analogs and doing this 360 scan, it makes life so much easier and importantly more accurate. So attaching the scan flags and scanning the bridge 360 in your hand is your 4th intraoral scan. With the bridge out, If you're doing it on MUAs, which the majority of these workflows are, we're going to ask you to put the MUA caps back onto the MUAs and do a soft tissue scan. So this is your 5th scan. Okay, pretty simple now for most of the scanners to be able to pick this information up. The key is not to go back and forward and back and forward. The key is to try to keep the scan nice and smooth, so don't confuse the scanner. And then your 6th and last iOS scan is purely dependent on the pathway that you've chosen. Okay, so be that the photogrammetry pathway, grammetry OptiSplint, grammetry ArchBridge, or the iJig, and I will take you through each of these. If you've decided on the photogrammetry pathway, then all you need to do is screw down or the scan bodies that come with your photogrammetry kit. What you see on the screen is iMetric, probably one of the most popular, and the iCam, and you follow the manufacturer's requirement. You must ensure that these are screwed down correctly, that they are not damaged. If they are damaged, then you will have to replace them. You will have an error in your scan, okay, or an error all the way through to your final bridge. So it's very important that you understand that these scan bodies don't last forever. I think iMetric, you have to replace them every 40 to 50 scans. So it is important that you do that and be careful that they are not damaged, okay, because that will introduce errors to what is a very accurate system. Okay, so if it's photogrammetry, you use the scan flag of the OEM company and you follow their instructions. If you've decided to use our horizontal scan body, this is what it looks like. This is the ArchBridge kit. Across the top row, you will see 10 individual scannable scan bodies. These have all got removable screws, which are at the bottom. Okay, they are screwed in place by the vortex screw. That means that if your screw gets worn or damaged, you can simply replace it without having to replace the whole scan body, which is a very good thing. And each of these scan bodies are screwed down in place on top of the MUAs. You also have scannable analogs in the lower left-hand side of the kit. And these are all sandblasted to make them easy to scan. This is what you place into the base of your bridge. Okay, so everything you need is within that kit. And as I've said, it is reusable. And what you do is you then place the ArchBridge scan bodies along the arch. You're trying to create a pathway for this iOS scanner that is going to be one sweep and smooth, and you do not want them to touch. Okay, that's very important. And you can mix and match them as you want. You can have some overlap, you can have them toe to tail, it doesn't really matter, but you want to create a nice scannable pathway. All right. And it's important that you understand that this is the information that the lab requires. Okay, we don't need the buckle, we don't need the pallet, we really need the occlusal surface of the ArchBridge scan bodies, because that's how we stitch it together. You've also provided us with all the other information, soft tissue, bite, vertical, everything else we've already got if you followed the scan sequence. Okay, and then if you use OptiSplint, OptiSplint comes with your order, depending on whether it's 4, 5, or 6 implants in the arch. And inside this little green box, you're going to have the various components of your OptiSplint kit. Each OptiSplint scan body is single use and is screwed in place with a specific screw that comes with it in the box. Okay, so what you do is you use a uni-grip screwdriver and you screw down each of the scan bodies onto the MUAs. They must not touch and they must aim palletly. They've all got little arms on them. You can see it just about here and underneath the honeycomb grid, which you then lute in place. So you put the scan body on, aim them palletly, make sure they are not touching. So it's different to ArchBridge, which is placed along the ridge. These are placed towards the pallet, and you lute them together with this honeycomb and use composite, or we prefer what is called stellar. And we find that white is easier to scan than pink. And then you can do an optional iOS scan of it in the mouth. But ultimately what we want you to do is to unscrew it, you've now got an actual verification jig, which can be digitized whenever you send it back to the lab. So what we will do is we will lab scan that, which will be a lot more accurate than you scanning it in the mouth with your iOS. Okay, so you're going to take it out, you're going to carefully package it, and you're going to send it back to us. And now we've got the 6th scan. The iJig is the only one that we haven't covered, and the iJig is just using normal scan bodies from your implant system. Okay, hopefully it will be on AMUAs if you're being kind to us and yourself, but also if it has to be on some of these refurb cases, perhaps it can also be direct to fixture. And you're going to scan that with your iOS. And remember, as I showed you on the video, that's going to be the most inaccurate. Okay, and that's the reason that with the iJig, we have to add in a verification step, which I will show you shortly. So on all the other 3, we don't have a specific extra verification step in the workflow, but with iJig, we must do it. All right. So we've also created for you a checklist, which has your 6 iOS scans and your 6 photographs, which you can tick off, and then you can order via the website, which again, I'll show you in a little minute. So that's the workflow for a temporary bridge. You now have to have a workflow for a removable. So again, 6 photographs at the start, exactly the same, don't change. But what we need you to do is we need you to make sure that the denture that the patient is wearing is well adjusted over the top of the implants, okay? And make sure that it's sitting down passively with some space around the acrylic. It's not hitting directly onto the implant if you can help it. And what we're going to ask you to do is then perform a silicone wash off that denture. And what we're looking for you to do is capture the detail of the MUA caps along the arch. Okay. And then what you're going to do is you're going to scan that denture. This is your first iOS scan. Okay. So you're going to capture the denture inclusive of the fit surface, because we need to see where the MUA caps are. That can be a slightly difficult scan to take, and you might have to have a few goes, and that might take a little bit of practice to get that scan correct. But there are certain ways to scan it to make life a little bit easier. You don't have to worry too much on the upper arch for the palate, the shiny palate, which is the most difficult place to scan, but make sure you capture the teeth, the buccal, and the fit surface. The silicone should be very easy to scan. Then that's your first scan. Your second scan now with the denture out is to scan the soft tissue, just as we did in the previous workflow. And then you're going to capture that series of 3 scans: denture in the mouth, occlusion, and opposing. Okay, so now we've got 5 scans. And then our last scan is exactly the same process. You can either choose photogrammetry, arch bridge, so just the same as I described earlier on, or OptiSplint, because we now have to pick up the implant position, or of course the iJig. Okay, so remember, 6 iOS scans for either option, 6 photographs. The only real difference is the capture of the denture and the MUA caps rather than a fixed bridge and the 360 scan of the bridge. You're still 360 scanning either, it's just a slightly different scan. Okay, again, we've created a checklist for this workflow so you can see exactly the scans that are required. And then it comes into what happens next. So with the iJig workflow, remember, we have to add in a verification step. And that's because the iOS from vertical scan bodies is not accurate enough to skip it. Okay. So what we do is we create for you a temporary or a try-in bridge that acts as a verification jig. And it is sectioned into each or across each implant, and it is held together by an Essex retainer type of plastic, which is either printed or vacuum molded over the temporary bridge, which allow you to seat it into place. You screw it down, tighten all your screws, remove the Essex or remove the little carrier, and then you lute it all together. And you can lute it together with composite or stellar again, but you have to make sure that it's really well luted together. Okay, and then you're going to adjust the bite. You're going to make sure the vertical is correct. Remember, this is based on our initial design from the records you've sent us. And if you feel that there is an issue with the soft tissue profile, you're going to reline it. Okay, so now we're going to reaffirm our soft tissue, our vertical, our bite, and our verification. And we take that back into the lab. We will now create our master model. We will digitize everything, and then we can go ahead and make you quite often another try-in just to make sure everything is okay, and then you can go to final. So the iJig is a slightly different workflow, but there are certain parts of that where you can go direct from iJig direct to final, so that leaves you at 3 appointments. Okay, but it's a very, very useful tool. I want to just cover a couple of little advantages with the OptiSplint, which are important to understand. So photogrammetry and DigiBridge are model free. OptiSplint, one of the main advantages we have is that we can create a model. This model we can then use as a visual verification in the lab. So the splint that you have picked up, the OptiSplint, we create a physical model for it, which is our verification check. And because we can lab scan it in the lab, which is more accurate than iOS, we can offer you the option of going direct to MUA with your final restoration. Now, what does that mean? That means that you can create the zirconia with no metal interface. So potentially don't need passive tie base or any other type of tie base as an interim. You can actually go straight, and we use what's called the vortex screw. So there's only 2 workflows that allow you to go direct to MUA, and that is photogrammetry because of the accuracy, but we can give you the same accuracy as photogrammetry using the OptiSplint grammetry OptiSplint workflow because we can lab scan it in the lab. So it's quite a neat little thing that can be done. And so this sometimes depends on just the type of restoration and the criteria that you have, which will push you down a certain pathway. This is just a lab scan of the OptiSplint. So once we have the records, okay, and we're happy with everything, you then receive from us a little ExoCAD viewer, which is where you can view the bridge that has been designed. Okay, this can be opened on any Windows computer. You just hit the link that we send you, and you can have a look at the temporary bridge. You can take off and on various layers. And if you're happy at this point and you wish to go to final, then you just need to let us know and we will go straight to manufacture. And that will be done within 15 days. Or if you want to have a try-in interim stage, that's also no problem. You just need to let us know, and we have 2 options. We will either print that and send it out to you, or if you have in-house printing facilities, we will send you the STL, and you can print it in-house to verify that everything looks and is okay exactly as it has been designed. Also at this point, you can add and decide to add in a titanium bar inside the bridge, which we call the Q bar. Okay. So once we've got through the potential try-in, although as I've said, most cases we don't need to do that depending on the records. Here you have a final zirconia bridge on the left-hand side, a monolithic zirconia bridge with the passive tie bases, or you can use an option of having a Q bar within your bridge if that's what you so wish. Okay, so there are some options when you come to the end. And here's just a couple of quick case examples. So these are all being done by myself. This is where we've done a dual arch in 2 appointments. So from temporary bridge to final in 2 visits. The first visit is about 45 minutes. The second visit is probably 20 to 30 minutes to fit. So a very, very fast way to get to a predictable end result, and we used the arch bridge kit for this example. This is a dual arch. This happened to be a guided surgery case, and this is Brendan. Just a couple of quick photographs. Brendan, this is him with his temporaries, and going through the workflow of the temporary bridge workflow that I've just explained to you. These are his arch and bridge scan bodies in place. We were able to take that record through to the lab. Okay, these are his scans, and produce for him 2 zirconia bridges, which we could fit at his next visit. And I have found this to be an incredibly predictable way to work. Okay, so that's Brendan finished. This is another arch bridge case, only this is the pterygoid case. Again, this is a 2 appointments, but it's a single arch. This was actually a rescue case that we did with guided smile in the upper arch where old implants had to come out. She also had the lower arch restored previously, about 12 months previously. So we knew that we were going to have to deal with this upper. So the implants all came out in one day, new implants were placed, and she went through sitting in her temporary. And these are the 6 scans, so the 360, the soft tissue, the bridge in situ, the opposing and the bite, and the iOS scan of the scan flags. Here is a very quick video of capturing that information. So this is the bridge in place. You'll see that the pterygoids haven't been picked up in the temporary. This is the opposing. Here's the soft tissue. And here should be the scan bodies. So that's the arch bridge scan bodies. And this is the 360 of the bridge. This is often the hardest scan to capture, and it can take a little bit of time. Some scanners are better at it than others, but you sort of just have to get into a system and remember that the scanner, you don't want to confuse it. So you can often overscan these things, and that results in the scanner starting to duplicate data. So you do have to be a little bit careful. And then it's put through the software. Oh, no, I did it quick. Put through the software. Sorry. And this was the result. So this was the bridge I showed you. And this is the particular patient finished now with her upper arch. That was just again in 2 appointments from the temporary bridge to the final. And this is another case, slightly different case this time. This is using the OptiSplint again. This is another implant rescue case. We do seem to get a few of them. And failing implants, upper and lower arch. Bridge had to be removed. It was an old straight to fixture bonded bridge. We put the OptiSplint, we changed it over to MUAs. We knew we were going to lose these implants, but I wanted a temporary bridge in the interim. So we could take the information from the original bridge, OptiSplint it on MUAs, so we had a very accurate record, and we could print a temporary direct to the MUA using the vortex screw, which we could fit for the patient. And this allowed us to put the patient into a more stable situation, allow us to do guided surgery planning, where we managed to remove the upper and lower failing implants, place new implants, ultimately put the patient into new implant retained temporaries on the day of surgery, and then using the protocol I've explained already, which is the conversion of the temporary bridge to the final, we could go straight to dual arch final bridges in 2 appointments. So a really nice, predictable way to work once you understand the workflow, and obviously once you work with a lab which also understands what you're doing. So we've created this very simple table to help you decide in terms of each of these 4 pathways what would be perhaps most suitable. So there are some key considerations when selecting it. Number 1 is simply the technology available. If you have photogrammetry, brilliant, you go down the left-hand side, which is here. If you don't, you've got the options of the other 3 pathways. Number 2 is your clinical requirements and preference. So you have to think about what interface do you want. Do you want to go direct to MUA with no metal interface? If you do, you can see here, direct MUA is only available on photogrammetry and OptiSplint because we can lab scan it, as I explained. If you're happy with a tie-based interface, then you can go for ArchBridge, OptiSplint, or iJig. And if you want to go direct to fixture, you only can use the iJig protocol. They all can have a bar added. You just need to let us know. And then down in here, we have some chair side requirements. There's certain drivers that you need to be aware of, things that are important that you don't miss out. And then you've got your turnaround times at the bottom. So choosing the right option is important. It allows you to start in the correct way at the beginning. And we, as I said at the start, we do take a lot of phone calls from dentists who need help in terms of just deciding what route to go down. We've also looked very carefully at how this is put together, and we've given you, as we've done with many of the other products in the lab, very transparent and fixed pricing. And so we've settled at a single price of $2,995 for everything. So this includes your final zirconia bridge with the high definition milling included, all the design work, the temporization, be it printed or STL for in-house print, doesn't matter. If you need to go through that stage, it's included in the price. If you use vortex screws for direct MUA, it's also included, as are your compatible components. So we've partnered with IPD, like we've done with some of our other product ranges, to provide all the components within the bridges, should it be analogues and screws and various tie bases, that's all there. All your models, should we need to make any models, you get a 5-year guarantee on the bridge. And if you use the OptiSplint kit, so grammetry OptiSplint, that is also included in the price. The only slight difference is dependent on the number of implants. And that just simply goes up by, I think it's £65 per implant. Okay, so it's a fixed price. We've also then been able to create a dynamic web ordering process for this. And this works extremely well, but there's some very specific reasons why we want an online order. Online ordering is relatively new for dentists to order from dental laboratories. We do it for anything that is relatively complex, that requires quite a lot of information, because we find that having a complete one-time data capture massively saves time, not only in the practice situation, but also in the laboratory. It massively reduces the need for us to chase you. In the digital world, so many cases come in with missing records or incomplete records. And as the case ramps up to full arch, we need to make sure that we reduce that. So this allows for us to close the number of potential gaps in the information submitted. It's more efficient and creates less delays for the case to get started. The website ordering is dynamic. So it's set up that as you input your information, the questions that it's going to ask you are relevant to your case. So you're not going to be asked iJig questions for a photogrammetry workflow, okay, or photogrammetry pathway. It'll be relevant to what you're doing. And this results in very clear information that it's asking you, with less confusion and less or reduced risk of error. It also will have very simple buttons that you can click on to download your workflows at that stage, again, dependent on the information that you're giving it. Obviously, the pricing, as I've explained, is clear and fixed, with some optional upgrades which are there, such as a bar, etc. So ultimately, when you're finished your order, you're going to have your final price displayed, which helps you in terms of your management of that in-house. And overall, this creates a much more efficient administration, because as the digital side of dentistry has increased, so has the administration side within a lab. And this is often unseen by dental practices. I get it. Not that many dentists visit labs and sees what goes on or understands it. but the digital management of the data and the information is hugely administrative heavy. So we need to make sure that we can, for us to be able to give you an efficient service at a competitive price, everything has to run smoothly. And so this is one of the main reasons that online ordering works so well for these types of cases. So just to summarize really some of the benefits of DigiBridge, as I demonstrated to you, it is really possible to do this in 2 appointments. But all of these factors have to come together if you really want to create that efficiency and to streamline the route to be able to give you full hours delivery very predictably. So it's really, really possible. We can guarantee you passivity, so that confidence in the first time fit with the new Passivity Plus tie base. It's an amazing addition to what we're able to do for customers, and certainly the use of it so far has been very positive. We can give you clarity to know where you stand, giving you simplified pathways and workflows to being able to give you fixed, transparent pricing. We like to think we know what we're doing in terms of being able, I suppose, to generate a product range like this. We have to have experience across each of the pathways we've explained, which we do. And also we've really trained our team now to really try to reduce the amount of errors and gaps that exist within this, but it is massively important that the information coming in is correct. Hence the online ordering for this. We're doing more and more full arch work. And when information comes in lots of different ways, it just creates more potential for problems. So that is why with DigiBridge, it will be accepted as an online order only, and definitely helps the process. We hope that we can provide greater profitability for practices in doing this, and you can enjoy the real commercial advantage that comes from digital workflows, because there's no doubt that it's there. But importantly, you have some clinical flexibility to allow you to stay in control of what you want to do. And that's really how it's been designed. If you want to scan, this is the CPD cert and event feedback. If you scan this, you will be brought into a feedback form, and all you need to do is fill that feedback form in, and you will automatically be given your CPD certificate. So I hope that's pretty clear. For those that are watching on recording, they can just do the same. They can just scan this, to my knowledge, and you will be able to receive your CPD cert in the same way. So thank you very much for anybody that's been able to give up an hour of their time. Oh, we're over an hour now. For the webinar, I hope it's been useful, and I'm happy to answer any questions.
No questions, James, just at
No
the
questions,
moment.
yeah. That's okay. That's no problem. Thank you, Colin. Glad you find it helpful. No problem, Paul. Pleasure. Problem, Ruth. Thank you. Does this only need one? Okay. So, oh, there was a question flashed in there. No problem, Aoife. That's great. Glad you enjoyed it. No problem, Michelle. Pleasure. Look forward to your first case. Think you have one coming soon.
James, there's just a question in there from Steve.
Yeah.
Does this only need one pickup at surgery?
So I'm not entirely sure what Steve is asking me there. Can you elaborate, Steve, just? That's okay. I'll do my best to answer it. Chrome cases. Yes, you can absolutely use it for Chrome cases that are already in the pipeline. That's fine. For some reason, I'm not seeing the questions. Here, I was in the wrong place. Sorry, folks. Can we use this for Chrome cases already completed surgery? You can listen. You can still follow the rapid appliance. That's no problem. What we will probably end up doing, Colin, is with the rapid protocol, we'll give an option to add in the passivity plus tie base. I think that's probably where we will go with this. Although the rapid appliance works extremely well as a process, it's brilliant. It maybe just gives a little bit more confidence if we add in the passivity plus. So that is, I think, something we will be looking at pretty soon to be adding in. If you wanted to do guided surgery and not have the rapid and then use one of the digital protocols to finish, that's no problem. You could opt for, there is already guided smile OptiSplint, which exists, which is where you can exchange your rapid appliance for an OptiSplint kit. So there are some options there, Colin, if you want to do it. Scanning various studies recommend various motions. Yeah, so like if you look at OptiSplint, whenever you're scanning that in the mouth, if you imagine all of the scan bodies are pointed in towards the palate, you're best to start in the palate, work out to the buccal, up and down each scan body. You don't want to really scan across it because in OptiSplint, all the scan bodies are the same. Okay, they all look the same. So if you scan across the top of them where they meet the implants, where they screw down onto the MUAs, you'll confuse your scanner. So you need to go out to the bit that looks different to the scanner, which is the honeycomb bit that you've luted in. So you would scan out and back, and that technique works very well. When you're scanning something like ArchBridge, which is along the arch, each of those scan bodies is uniquely different. So theoretically, your scanner shouldn't get confused, but often where it gets confused is when people go back and forward, back and forward, back and forward. Really, you want to start nice and steady and just work a nice sweeping scan across the arch. So it depends slightly on the type of scan body you're using. Like if you're using vertical scan bodies that are all the same across the arch, maybe in 4-6 implants, that can be more difficult to scan. And each scanner will often have a certain defined pathway associated with it. Like iTeros will be slightly different to 3Shapes, and you're best to follow that pattern for that scanner. Hope that helps. Oh, Steve, yes, so you've got your question. Thank you. I'm glad. Being 3Y zirconia are graduated. We use monolithic, we use layered. So we used high translucency from argon is what we use. And we found, so we've used a couple of different zirconias. We found that we've made a couple of changes. I think that's questions from Julian. We've made a few changes in terms of how we manage the zirconia. The biggest change has been the milling. We've really upped our milling, and that's why I was talking about the importance of the CAM aspect of it all. If you're milling direct onto MUA, you really have to have a milling machine that's able to manage that type of milling process. The burrs, how the cam is all put together, the size of the machine, the mobility of the machine and the axis, all of those things are really important. And so in probably October of last year, we totally changed our milling. We brought in somebody specific to just do the cam because we really realized that the more of this type of work we were doing, potentially the more problems we could have in terms of the management of that zirconia. So we tried to improve the milling process and simplify the stages. So the less hands on that zirconia in its green state, the better. So the less carving that has to happen post-milling, we found is one of the major advantages. So we mill on a C-clamp on what's called an AS1 machine. So it's exactly the same as SkillBond, actually. It's their strategies that we have, and it mills beautifully. And we found that it's actually coming out of the milling machine with no post-op carving to do. And what that does, it reduces the chance of microfractures through the zirconia. Okay, so reducing those fractures, which maybe we can't see, they might come out in the sintering oven, or unfortunately, they might come out for you in the mouth at some point. And if you add some lack of passivity to that, then that's a greater chance of you having a problem. So we have found a huge improvement in that process by adding in all of those little improvements. So milling, cam, strategy, less handling of the zirconia, that's improved. So it's not just a simple matter of what is the type of zirconia, probably, Julian. Like we could give the best zirconia to 5 different labs, and if they've all slightly different internal processes, they will all probably end up with slightly different results and predictability from that material. So we have sort of looked at it in terms of the entire process and went through each of those bits to try to reduce the chance of error, if that makes sense. So what we use is Argon HT Ultra, I think it's called. I would need to go and check that for you, but yeah. So I'm not sure if there's any other questions. I know we've run over a little bit. If anybody is, interested and wants if you go on to the website and just go on to DigiBridge on the website, so www, I'll just type it in, chorus3d.com. Oh yeah, I'll talk about the bar now in a wee second. Yeah, chorus3d.com, and go on to the DigiBridge part. You will be able to download a DigiBridge sort of quick guide, which sort of outlines everything I've really talked about, actually. Yes, the bar is designed in-house, so we actually design it on RealGuide. We have found, Blender slightly different. We found that it's just not as accurate. A lot of labs use that. So we design it on RealGuide, and then we mill it in-house. So we have full control over it. And we found, Shah, that works really well. Like we started doing this very quietly about 5-6 months ago. And we've just been working in our internal processes just to make sure that we're really trying to refine this as well as we possibly can. And we're very, very, very happy with the results now that we're getting. So yeah, everything's done in-house. We don't send anything out. We have found that the more things we send out, the more probable complications we have. So we have our own designers employed by the business. We have our own CAM. We have our own machinery, which allows us to be able to pull all of this together. Yeah.
James, that's all the questions just on the
no problem.
chat, all answered.
Yeah. So we have an email which is dedicated to DigiBridge, which you can email if you have any other questions, and somebody will pick that up. But hopefully I've been able to at least give you a good overview of what's involved in the workflows that we have decided at this stage to follow. All right. Thank you very much, everybody, and have a nice evening.